I'm Shamia, Radiation Therapy Technologist at JPMC Karachi. And today my topic of presentation is the setup verification protocols of head and neck and pelvic cancer on Radixact X9 tomotherapy system. Through this presentation, I will walk you the need, challenges, and the setup verification protocols using in the precise treatment of the cancer. Introduction. Basically, the tomotherapy combines the two vital components. One is the tomography, which is the imaging section or the slice-by-slice imaging, and the second one is the radiation therapy, the delivery of the radiation in different perspectives. The system is revolutionary because it provides the precise treatment of the tumor anywhere in the body by using a slip ring technology and the 6 MV energy linear accelerator around the patient body while targeting the tumor precisely and saving the surrounding normal healthy tissues. And this approach makes it unique to enhance the quality of life and the patient comfort during the course of the treatment. This is a 360-degree rotation treatment so there is no chance of the tumor to be eliminated from the radiation. So why there is a need of setup verification before proceeding any type of the radiation therapy? Basically, when we are doing the cancer therapy through the radiation, the patient anatomy changes with time or during the course of the time. And these changes may be due to the loss of patient weight or the tumor has been shrink or any other socioeconomic factors. And secondly, there is an organ motion, which is a normal organ motions everybody possesses, and that organ motions can decreases the certainties of targeting the tumor more precisely. And to overcome these two things, the volumetric imaging came into the role by providing us to quantify these motions, these errors, these changes, and correct them before proceeding any radiation therapy to the patient. So there are some challenges one has to face before proceeding. One, it raises the risk that if the improper verification takes place, there is a chances that the tumor will not receive the significant or intended amount of radiation. Secondly, there is the higher risk of normal tissue complications that will receive the unintended radiation doses. And third one is the geographical misses, which means the radiation itself misses the part of the tumor, and that becomes the reason of the tumor recurrence in the body. This will all lead to the psychological impact on the patient, where the anxiety level increases, and lastly, this all lead to the higher workload on the clinical team, because the readjustments and realignments or replanning might become necessary. So implementing the verification protocol before proceeding any treatment is necessary. Otherwise, the patient will suffer, the clinical team will suffer. These are the different studies that highlights the importance of the image-guided radiation therapy and the treatment overall outcomes. There is a clear link or highlight markers that evolves or that says that imaging before the radiation therapy is mandatory for the overall treatment outcome and accuracy. In tomotherapy, we have verification protocols by two means. One is taking the daily setup verification, which we acquired on the daily MVCT imaging, mega voltage computed tomography, and second is the visual inspection of that MVCT images to identify and correct the patient position and any misalignment if happened due to poor setup verification. For the comprehensive setup verification protocols, several key factors includes, which means that we have the pre-treatment planning. To acquire the setup, we have to verify the setup, we have to acquire the setup. And that includes the pre-treatment planning. Second is the patient positioning. Third is the image registration. And fourth is the treatment verification. These are the 4 steps which we follow each day to deliver the precise radiation to the tumor. Number 1 is a pre-treatment planning. This starts with acquiring the planning images. Keep in mind that acquiring plan image we used as a reference image, which is a KVCT image. On that, the position and the 3D anatomical data of the patient has acquired. Immobilization devices are used at this stage to minimize the patient movement and to minimize the error of alignment. Second is the contoured structure, which is a part of the clinician, where the clinician delineates the gross tumor volumes and the organ at risk around the tumor. Third is the create the treatment plan, which is the creation of the optimized IMRT precise plan. These 3 steps then underwent the quality assurance program to demonstrate the dose constraint to organ at risk and the tumor will receive. This should be in the tolerable limits. So before proceeding any treatment to the patient, every plan must undergo these 4 steps. And after preparation and the quality assurance of the plan is sent to the treatment delivery console, where the verification of the setup starts. Second is the patient setup and imaging. Patient position in radiation therapy is quite crucial, because if the patient is not in the right position, that radiation will hit the normal tissues and there is the increased complication of normal tissue damage. So for the pelvic cases, if we want to treat the pelvic cases, the patient position is aligned with the bony landmarks. And other is the organ motion. We have to manage the bladder and rectal status, because the variability, to reduce the variability of these organ in positions. Third, for the patient position alignment, we have to rely on the fiducial markers in case of prostate cancer. For head and neck cancers, we have to align the upper cervical spine of the patient. Neck should be straight and elevated. These are used for the patient position to keep in aligned position so the radiation can hit the target effectively. These are some of the immobilization devices we used to minimize the patient motion, and that's the decrease the misalignments or error in motion. These are the face mask, headrest, shoulder retractor for head and neck cancers, while the back and the knee flexor are used for the pelvic radiation therapies, including the cervical cancer, prostate cancer, or rectal cancer, bladder cancer. Every organ in the pelvis, we have to use the immobilization devices to restrict the patient motion. Here is the third parameter, which is the image registration. Keep in mind that we have a planned reference CT scan, which is a KVCT scan, and on-board imaging on the console, we have the MVCT imaging. The MVCT image should match with the KVCT reference image in 3 manners. One is the bony landmark, second is the soft tissue based, and third is the contour based. Contour based, which means the target, yani tumor or organ at risk. The MVCT bones, soft tissues and contours must match with the bones, soft tissue and contours of the reference planned CT. MVCT is a mandatory tool in tomotherapy for the verification of patient, and a pre-treatment MVCT is taken. Radixact system on the treatment day act as a scanner and a delivery machine, and that make us to fetch the data of the patient anatomy in the 3 dimension on daily basis. We can see the picture of the patient inside the body, what is happening on day-to-day basis, on daily basis, by the help of the MVCT imaging on treatment console. A pre-treatment MVCT scan must align with the planning KVCT slice by slice. This allows the repositioning of patient, and if any variation, interfraction motion can be corrected. Okay. The MVCT image and the KVCT image must match with each other. And obviously, this is not possible on every day. Everyday patient cannot acquire the same position as he or she acquired on the treatment planning day, simulation day. So when we acquired the MVCT images, there is a little differences between the MVCT image and the KVCT images. And we have to eliminate that differences. To eliminate that differences, there is a way. The gantry of the tomotherapy Radixact system and the couch of the system, they come into play by taking the certain position in X, Y, and Z planes, which is the lateral movements, longitudinal movements, and the vertical axis, to give the 360-degree treatment to the tumor. To eliminate that differences, gantry and couch work together on the X, Y, Z planes to match the bones, soft tissues, and the contours in 3 axes by acquiring the position. Okay. Here is our X, Y, Z planes where the gantry and the couch takes the position to eliminate the difference between MVCT and the KVCT. The static image is the KVCT image, which is acquired on the planning date, simulation day. And the dynamic one is the MVCT image. This is the automatic registration. There are 2 types of registration algorithms are used to match the MVCT and KVCT images. One is the automatic, which is performed by the software, and the other one is the manual algorithm, which is performed by the radiation therapist. This is the automatic registration algorithm where the MVCT of the image matches to the KVCT or the reference image in the XYZ plane by matching the bones, soft tissues, and contours. Here the overlaying or matching takes place in the tomotherapy Radixact system. This is an interface of our software. Here for the pelvic patient, the first is the scan, which is the MVCT scan on daily basis. Second is the registration image, in which the gray one is the reference CT and the blue one is the MVCT images. We can pinpoint each and every differences by using the MVCT as a checker at any level, slice by slice. And after executing the differences and eliminate the differences, one can execute the treatment. Here is another example. First one is a simulation, then KVCT image. Second is the MVCT image, including the bladder filling and empty rectal status. And in the fusion, you can see the bladder, rectum, bony soft tissues, and the contour. Here, the 3 plans of image registrations takes place. And if we see the contoured image registration tells us here, the red circle encircles that the patient has a weight loss here. The bones are matched, rectal and bladder status are fully matched, but the contour tells us here that there is a weight loss. The clinician now take into consideration further fractions for some days and then change the strategies if these changes persist consistently. For the head and neck, this is a case of the retromolar trigon cancer. These are the MVCT slices. Here, the gray one is the KVCT or the reference image, and the blue one is the MVCT images. The registration after the automatic and the manual registration takes place, see there is some sort of the values in there. So the system and the technologists who are on charge will need to rectify and minimize these values. And after image registration and algorithmic changes, these values are now going to 0.1, which shows the precision of the tomotherapy system that only the 0.1% is remaining the difference. And this depicts the precision of tomotherapy system. Number 4 is the treatment verification. All 3 steps were made to align the patient, correctly deliver the radiation in the correct position, minimizes the errors. But what about the radiation doses, which is the aim of the radiation therapy, to treat the cancer with radiation? So here we have the 2 types of processes. One is the online process, which is a IGRT based, and second is the offline verification protocol, in which we can see the ongoing changes inside the body of the patient on daily basis. If the patient has a prescription of 30 days, we can check the progress of 30 days. Secondly, it gives the dose constraints. It tells whether the planned dose is delivered to the target volume or not. So to acquire this, we have an option of precise RT that gives you the planned doses as well as the delivered doses. It means the clinician decides that this amount of radiation should be delivered to the target to eliminate them. And the second one will show you that these are the delivered values, these are the delivered doses that the patient has achieved. If any deviation takes place between the dose constraints, the replanning or the re-CT is prescribed to the patient. So in tomotherapy, we can align the patient, reduces the error to 0.1 degree up to, and also check the doses of radiation precisely delivered or not. So this will lead to the proper treatment of the patient, or the survival of the patient increases by eliminating the disease. And the last one is the adaptive strategies, which means that the clinician can adapt to re-CT the patient or reacquire the CT and then plan on it again for the conformal radiation therapy or the advanced radiation therapy to delineate the tumor and save the organ at risk if the normal structures are not within the tolerable limits. Okay. To conclude this, if the clinician wish to a prolonged survival, so the setup verification protocols must be managed on daily basis by using the advanced modalities in tomotherapy, like we have MVCTs and other have the different sort of daily imaging like KVCTs and cone beam CTs. We are dealing with the MVCTs, and one has to account the accuracy of the treatment throughout the course of the patient. Thank you. If you have any question. Ji sir?
Talk about the face mask.
Yes sir.
If some patient come for radiation, after 3 or 4 cycle of radiation, patient have a massive swelling on our face. What we will do? Stop the radiation, or without mask we will do it that radiation?
Without face mask we cannot execute the radiation, because face mask is necessary to restrict the patient because of markers. Because of markers, yes, we have alignment on the markers, but we cannot, if we have markers on the neck side or not on the mask, still we cannot proceed the radiation without the face mask, because the face cannot be straight until the whole of the treatment. And for the swelling, we need to check why there is a swelling. We need to rectify that, send to the clinician, or check whether there is a swelling is due to the increase in the mask or some other factors are used.
We stop our radiation for some days?
We stop our radiation for some extent if the mask is not fitted to the patient face.
Okay, thank you.
Any other?
Other question, that anatomy wise, you told some time after radiation, anatomy changing, or weight loss or something. What we will do for that, for precautions of the patient?
During the course of treatment, the patient anatomy changes. It is mandatory. If it is not, then there is a reason. Patient anatomy changes because of 2 reasons. Either the patient weight loss, or second one is the tumor shrinkage. If the gross tumor was there and after some radiation hit that tumor, and then the tumor must be shrinkage. So that anatomy changes. And if that anatomy changes up to the tolerable limit, then we have to replan the patient. And that is why we have the adaptive strategies to look upon, to check the changes as well as the dose. Because when anatomy changes, the dose to the target and the organ must be changes, obviously. So we have to take the adaptive strategies. Thank you. Any other?